and talk about the cardiac enzymes and from a unique perspective. So hopefully after today's lecture series, the cases that you will go over on Thursday and Friday, it shouldn't be a big thing. And then I just got to put in a plug in again. Dr. Betledge will be here live tomorrow. So
and he's driving a long way to come here.
He's driving a long way, and I know. But I told him he doesn't. It's not 8. It's 9:30. So he'll just be here half an hour to take some of your questions, and then he has a couple of lectures which shouldn't take him that long, and then that finishes up our sort of cardiac pathology week, with one exception. Next week, and I'll send an announcement about this, a regional expert on congenital heart disease. She'll be here. She'll be bringing a lot of her pediatric hearts that she brings with her, Dr. Barati. And so I will, last year was really well received. So we're going to do the exact same thing as we did last year. So I'll send out an announcement about that for next week. So that's the only piece of cardiac path you've not had, with the congenital piece.
And I would say it's really, really worthwhile attending. I'm a pathologist, and every time she does it, I learn something.
I learn too.
These are things that you just don't see or understand.
Right. So, all right, go ahead.
Thanks.
I'm guessing it's this top one.
I'm going to see when was it say? Yes, that's it.
Okay.
As of today. Recently updated. 10:31 a.m.
About 30 minutes ago.
Where is it? Why isn't it coming up?
It's popping up. Good. Okay. And
Thank you very much. Okay, so I'm going to talk about laboratory diagnosis of myocardial infarction, and these are some of the most common tests you're going to be ordering, I mean, if you're going to clinical practice. So you need to know about what the tests do, how they work, what value they have, and we'll cover it in this lecture. And I covered a broad range of things in this lecture. Only a couple of things that are really mission critical, and I will point out the mission critical things for those attending the lecture. Maybe I'll turn off Panopto for the special when I give you the question. Okay, so why do we care about this? Well, ERs are jammed with people, most of whom don't belong there, but there are a lot who come with chest pain, right? And so if you have chest pain, you go to the ER, right? And anyone here ever been to an ER, right? Okay, I had an injury. I went to the ER, hung around for like 5 hours, and I finally said to my wife, hey, I can come back in a week. It's not that bad. But you go to an ER with chest pain, you can't leave, right? You got to hang around. So, and diagnosis of acute myocardial infarction is not as easy as people think. Big differential diagnosis, right? I could have eaten Mexican food or Italian food and have heartburn. I could have been in an auto accident and gotten chest pain, right? I could be out in my kayak like I usually do for a bunch of hours and then I'm sore. Maybe I got pericarditis from some autoimmune disease. So there's a whole bunch of things that can cause chest pain. And with the myocardial infarction, a lot of patients have atypical pain, right? Doesn't have the classic radiating down the left arm, things like that, diaphoresis. And you've learned about EKGs. I know nothing about EKGs, but you've learned about EKGs. And so they're difficult, and sometimes you can't make interpretations, right? I remember when I took step 2, we had a different system when I was in medical school, and I was doing pathology, and I decided I would skip all the x-rays and all the EKGs to make my way through the test. And I got back my score, and I was frightened that people had gotten lower scores than me, and they actually looked at the x-rays. But anyway, I said, man, there's a real problem out there. I just made up answers. But anyway, so EKGs are hard to read, right? They're hard to read. It's not as simple as it looks. I don't mean by hard to read, but they're hard to interpret. They don't always they're not definitive. So cardiac markers, which we'll talk about, they're useful when the ECG is normal or maybe the person's had a previous myocardial infarction. Right bundle branch block is very common. Have you seen that in those EKGs, right? It's very common. So, and if you don't have a previous EKG or ECG to compare it to, it's hard to make a diagnosis. Sometimes a person will have an extension of a pre-existing MI. Hard to diagnose also on an EKG. It's also useful, the cardiac markers are useful for assessing prognosis. What's my long-term prognosis? That's what we were talking about over here. in terms of risk assessment, and then seeing how well reperfusion is going. So there's a lot of reasons these tests can be used. So my lectures are boring because I repeat the same thing over and over again, but sometimes it's useful. Repetition is good, right? So why are we measuring these things anyway, right? What are we measuring? Well, we're looking for substances in the blood that are released by damage from the heart. Let's be totally simplistic, right? The heart's been damaged, and if something unique that is contained in the heart gets released into the bloodstream or the lymphatics, and I can detect it, that can tell me there's injury to the heart, right? So I want something that's going to be released with injury, not something that's going to be released just normally, right? You know, it depends. Why is it being released? Is it from necrosis, or is it because there's increased cellular permeability from injury? How long does it stay elevated, right? If there's a marker that's elevated for 20 minutes and then returns to normal, you're never going to detect it, right? On the other hand, if there's something that stays elevated for a month, it might be less valuable because every time you see the patient will be elevated. So there's a time factor. How long does a marker stay elevated? Are there patterns we can look at? Is there a serial pattern? Does it rise rapidly and then fall off? And most important, which I like to stress all the time, because I'm head of the laboratories here, and as I like to tell people, half the tests that medical students and residents and attendings order are completely useless, but the problem is I don't know which half are useless, right? So you need to correlate test results with other things, right? Maybe it'd be nice to take a history, find out why the patient is in the state they're in, look at the ECG, look at a couple other things, see if they've got congestive heart failure, whatever. So you got to correlate this results with the patient's overall picture. Sad that a pathologist has to tell you that, but I think it's important, right? Look at the patient, get their name, right? As I was told in medical school, the patients know what's wrong with them, they just don't know how to tell you, okay? So it's your job to elucidate it. So markers enter the bloodstream different ways, lymphatic system, venous system. Depends how big the marker is, whether it's how fast it's going to be released, and also depends on the kind of infarction you have, how good a blood supply the area has. If you have an infarct in a very, very vascularized area of the heart, well, the markers are going to pass in quickly. If you have an area like the subendocardium, where it's not as richly vascularized, it might take longer for the markers to get in. Make sense? So these are all just little background pieces. So, you know, when we talk about things, we look at lab results. You ever notice you get a normal range? You get these lab results, and it's the word's really the wrong thing, right? It really should be reference range. What is typically expected in patients, 95% confidence interval with 95% of patients. So there are a lot of things that can affect the results of test results, any test result, right? Cell turnover, your age, your sex, right? Older you get, the less muscle mass you have. The methodology that's used. Depending on the method that's used, you might get different results. So there are a lot of things that go into it, and that's why you should be generally familiar with how the testing is done in your hospital, because that'll help you make interpretations. Okay, now this is not directly related to this topic, but I personally, since I went to public health school, I find this interesting. So you're going to have to listen to it whether you find it interesting or not. We have to think about the diagnostic utility of tests, right? So what's a good test? Well, it all depends. So sensitivity is the ability of a test to pick out abnormals, all right? That's a sensitive test. And a sensitive test is evaluated. We take all the true positives and we divide it by the true positives and the false negatives, right? Or, to simplify it, the true positives divided by all the abnormals. So it's a very simple concept. We have how many people in this room? I'm embarrassed to count them. There's one back there I can see. I see your head. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. I got 15 people in this room. So if I wanted a very, very sensitive test, I would say anyone in this room is a medical student, okay? And it would pick out 15 people, right? 13 medical students and 2 one youthful individual and one over-the-hill pathologist, all right? But there'd be 13 doctors picked up, but the test would be 100% sensitive, right? 100%, even though it's a stupid test, but you're in this room, and it proved it was right. 100% of the time it was right on the sensitivity. Okay? Does that make sense? So my example is a perfect example of what sensitivity is all about. In this case, the sensitivity would be 100% because there were 13 positives, right? And total of 13 abnormals. The two of us don't get counted in there in sensitivity because sensitivity is only looking for abnormals. Make sense? Now, what's specificity? That's negativity in normals. So it's just the opposite. So that's true negatives divided by true negatives and false positives, right? So that's all the true negatives divided by all the normal people, right? So in my test here, right, that I had, my test doesn't have 100% specificity, right? Because my test had 13, my specificity in this case, right, negativity in normals. Remember we were saying, are you a medical student, right? We're going to call medical student normal, I guess, right? Or not, no, negativity would be not being a medical student, right? That would be a normal, right? So in this case, there were two people who were improperly classified, right? So they were called medical students when they weren't, right? So we have to look at what's a true negative. So why is that important? Well, what really matters is the predicted value of a test. What I'm really interested in is not that by saying anyone in this room is a medical student and saying it's 100% sensitive, right? What I'm really interested in is how good is this test in predicting something? What's the batting average? Does that make sense? So when I say it's true positive, what's the likelihood that the patient really has the disease? Okay? So this takes into account both sensitivity, which is picking out the abnormals, and specificity, which is picking out the abnormals. Make sense so far? So the predicted value of a positive test is the true positives divided by the true positives plus the false positives, right? So the predicted value of my stupid test that I had would be 13 positives divided by 15 people, right? So it would be 13 out of 15. Does that make sense? Okay. The predicted value of a negative test is the true negatives divided by the true negatives plus false negatives, right? So that would be how many normal people get a negative result, right? My stupid test doesn't work because everyone here, right? Now, 13 divided by 15 is a pretty high predicted value, don't you think? That's like 85, 90%, 13 divided by 15. So you'd say, well, maybe that's not a bad test. On the other hand, if I went into a lecture room just like this in the nursing school and I applied my test, everyone in this room is a medical student, right? And if there were 15 people in the room, there might only be one medical student hanging around there, so the test wouldn't work. And why doesn't it work? The prevalence of the medical students is different. In this room, 13 out of 15 medical students are present, so any test works because almost everybody's a medical student. But when I go to a room where almost no one's a medical student, my test is a complete failure. Does that make sense? If it doesn't, raise your hand and I'll explain it to you, right? So the test you use is determined not only by how good the test is, but who are you testing? That's why many screening tests are ridiculous and don't work very well, okay? Many screening tests, which are fine for diagnosing an unhealthy person don't work well when you apply them to the general population, because so many people don't have the disease. The false positives far outweigh the true positives. And then you're chasing after patients who don't have a disease. Make sense? So let's give an example. I always like examples. Okay, let's imagine I have a test that's 100% sensitive. It's going to pick out all the positives, right? And it's 95% specific. That means 95% of the time it's going to pick out all the normals. Okay? Is that good so far? No? All right. So let's go to two different areas. If I go to the cardiac care unit and I say half the people in the cardiac care unit have MIs, right? That's the prevalence, right? You know what prevalence is? The number of people who have a disease at any given time. You know that? Now you do. Do you know what incidence is? The number of new cases per unit time, right? So we're interested in prevalence, right? So cardiac care unit, in my example, half the people have an MI. The test has a 100% sensitivity, 95% specificity. If I go to a random hospital unit, and then you see my predicted value of a positive test and a negative test. We're going to show you the math. And if I went to a routine hospital unit where only 5% of the people had an MI, the predicted value of a positive test is only 50%. Same test. How can that be? Anyone want to tell me? How can the same test have a different predicted value? Silence is deafening. Well, the prevalence is different. That 5% of the time that I'm making a mistake on negatives, you see the specificity? 5% of the time, I'm mistakenly calling someone positive when they're not. It's not such a big problem when most of the people have the disease, but it becomes a big problem when most of the people don't have the disease, right? My test, are you a medical student if you're sitting in this room? When everyone's a medical student, it works real well. When no one's a medical student, you know, not such a good test. So let's do the math. Cardiac care unit. Okay, 50 patients there, all right? 50 with an MI, 100 patients. 50 have an MI, 50 don't. So, my test, if you remember, is perfect. It picks out every single person with an MI, right? It was 100% sensitivity. So you notice how many we have with a test that's positive? Of the sick people? All of them, right? And none of them are negative. So we picked out all 50 positives. On the negatives, well, the test is almost perfect, but it's not totally perfect. So 5% of the patients it's going to misclassify. That's how I get 2 patients with the test positive. Even though they don't have the disease, right? The specificity is only 9. Does that make sense to everybody? You see the math? So of the 50 people who don't have the MI, it's going to misclassify 5%. I can't have half people, right? So I made it a 2. Okay, it makes the math better. And it picks out 48 people. So, right? The predicted value of a positive test, right, is I got picked out 100% of the time. True positives over all positives. But, right, that's the predicted value of a positive test. Predicted value of a negative test is 100%. Okay? Now, let's go to the general medical floor. Okay, 100 patients. Only 5 of them have an MI. Okay. So, 100% of the time I pick out the people, right? With the MI, I get my 5 people. Unfortunately, I make a mistake 5% of the time on the negatives. And what's the problem here? Most of the patients are negative, right? So a 5% error on 95 patients turns out to be 5 people. So the test is going to be positive in 10 people. 5 have the disease and 5 don't. Exact same test. So do you see why prevalence matters? right? Or not? Does this example make sense? So this is how one evaluates tests, and this is how, when you read about a test, the sensitivity of the test is interesting, the specificity is interesting, but that's really not what matters. What matters is the predicted value, predictive value, okay? I think it was 30 years ago, 25 years, I'll have to remember, I'm getting old. Maybe I was thinking about 25 years ago. I went down to Springfield to testify against the bill. And the bill they had was that they were going to require HIV, remember this? HIV testing when you want to get married, okay? So they thought this was a great idea, and they were going to protect the public from marrying someone who was positive for HIV. And this was in the first generation test that had a lot of false positives, 98%, but 2% false positives. And of course, my argument was that the vast majority of the people are going to be negative, right? The vast majority. So the test being wrong only 1% or 1.5% of the time, the vast majority of people who get a positive result aren't going to have an HIV infection. Does that make sense? Well, because it made so much sense, they passed the law anyway. And within about a year, there were articles in the newspaper all the time. Couples break up, they find out the test was wrong, and then eventually, quietly in the middle of the night, they deleted the requirement from the state. But do you see why that? All about prevalence. No one, they didn't understand this, right? So you understand it now. All right. So let's talk about cardiac markers, right? So we'll talk about how we get these numbers, but sensitivity, probably 50 to 60% in the first 3 hours. Why is that? Because it takes time for these markers to be released and get in the bloodstream. Remember I told you? It takes time. If you wait 6 or 8 hours, sensitivity is about 100%. Why is that? There's been a longer period of time allowed for the marker to get released. Does that make sense? That's why when a patient comes, how many people have volunteered in the ER? Okay, right? The patients come, they think they've had an MI, they come in, they sit down, they draw blood, throw the patient in a room, might be a nice room, but they sit in a room, no one comes to see them, right? And they're playing with their phone, they got bad reception, they get really, really mad. And then someone comes, well, that's what happens. And then 6 hours later or 5 hours later, they come in and draw their blood again, right? Then the lab result comes back, and now they've been sitting around 7 hours. They say, oh, you can go home. There's nothing wrong with you, right? And by the way, sign out and pay your bill. But that's because it's a serial test, right? We got to do one, and you got to follow it up. Is it possible the patient could come in with a positive test? Yeah, of course, because the patients don't show up at time. The patient doesn't go and then walk into the emergency room, right? Maybe they were in the middle of the night, they thought they ate something, didn't agree with them, and they felt bad, and they show up at the ER, and as soon as they do the test, it's positive. You don't have to wait, right? But if you come in feeling vaguely ill, like you had something, maybe you did, maybe you didn't, you got to have the first test is negative. You got to wait 6 hours because we got to wait for the test to be positive. Does that make sense? So that's the big conundrum. Is that the right word? Conundrum? Some word like that. That's the problem they have in an ER. The person's perfectly healthy, but we got to wait till get the next result because I got to rule it out, right? Because what's the big problem? I send the patient home who does have an MI, and they go home and then they die, right? That's a big problem, okay? For two reasons, right? One, the patient dies, and two, they hire a trial lawyer, right? And then there's a bigger problem for the people around. Okay, so you're laughing, but that's one of the big issues in ERs. That's why patients hang around so long, right? They know there's nothing wrong with the patient, but can't send them home. All right, let's talk about the markers. So what's the ideal feature of a cardiac marker? Going back to the tests we were talking about, highly sensitive. Going to pick out everybody who's got the disease. Highly specific. It's going to pick out everyone who doesn't have the disease, right? You want to become positive very early so the patient doesn't have to hang around for 2 days in the emergency room. We want a wide diagnostic window. Anyone know what that means? Want to guess? Yeah, go ahead.
It sticks around.
Yes, it sticks around. So what I was alluding to earlier, if If the test is positive for only an hour and the patient comes in 3 hours after their MI, test isn't any good, right? It was positive, but the diagnostic window has closed. A wide diagnostic window means the patient committing many, many hours or days afterwards and it'll be positive, right? So that's an important thing. And you would like to have a test that somehow can predict outcomes, you know, stratify patients, whether they're at higher risk in the future. And if you're doing reperfusion, does it say how well it's worked? You want to be able to get the test quickly. We don't want a test that takes a week to do. ER would be really crowded. We want it to be readily available. You want a test you can do anywhere. You know, there are tests you can do right in the ER. I think they even have them on some ambulances now. Quick blood tests that you can do so you can tell the hospital if it's positive or negative. Precise. Anyone know what precise means? No? No one knows what precise means? Okay. Well, there are two terms, accuracy and precision. Accuracy means the answer is correct. All right? So an accurate test gives the correct answer. A precise test gives the same answer repeatedly. Okay? So we prefer tests that, of course, that are accurate. But precision matters even more because you need to be able to reproduce the result over and over again. So when I come to the ER at time 0, I do a test, and if the answer is 1, when I repeat it in 6 hours, if the answer is 3, but it's not a very precise test and it could have been 1, the test is no good, right? So I need a test that's highly reproducible. That's always the battle in laboratory tests. It's not hard to get an accurate test that'll work right once in a while. It's much harder to get a test that's reproducible over and over and over again, okay? Right, when you're in an airplane, like I was landing this morning at 5:30 due to my delayed flight, I was very delighted to do that. You know, airline pilots are extremely precise when you land. They land in the same spot every single time. You ever watch planes land? They touch down the exact same spot. Very, very high precision. They're accurate too, but what's more important is they're precise, the same place over and over again. Okay, and you want an inexpensive test, but as you can imagine, anything that's good is never cheap, right? So there are a couple of different markers, and I got them in the order that we use them. Troponin, that's the test we use. There's 2 troponins, I and T. There's creatine kinase. It's an older test. I only mention it because I think sometimes historically it's a little bit good to understand how we got to where we are with the troponins, which is why I mentioned this test. And there's a very old test, myoglobin, which is not widely, it can be widely used. It's an easy test to do. And I'll explain why it can be used and why a lot of people use it and why some don't. So troponins are the gold standard, right? Anyone know what the gold standard stands for? We'll really see if anyone knows. Look at this. Look at this is a classic. Gold standards. Gold standard was the price of gold was fixed at $34 an ounce in 1935. So that's how much gold was worth. It was the gold standard. Okay, so gold was worth $35 an ounce. And American currency and other currencies were all tied to the gold standard. Okay? That all changed in 1970 when they dropped the gold standard, and then we started printing money like crazy, and then, you know, the price of gold went way up, right? So that's what the gold standard's from. You learned something today. All right. Who got rid of the gold standard? Anyone know? You didn't know what it was, so Richard Nixon, 1970. Okay. So troponin regulates muscle contraction. It's got 3 subunits, and there are 2 troponins, troponin T and troponin I. Okay? Usually undetectable in serum. Okay? And can stay elevated for up to 10 days. So what does that mean? It has a wide diagnostic for the people on Panopto, wide diagnostic window. Troponin T. Got it? Okay. And widely available. Do the test. You can do it here. If I had a test kit, we could do it right now and measure somebody. And the test is very precise. So that means you can do serial sampling, and you can really see if the values are going up or down, right? Hence, precision is important. I'm watching the time, don't worry. It's more specific than CKMB. Doesn't have any false negatives, okay? Excuse me, false positives. More sensitive, so it's very sensitive, doesn't have false negatives. So we like that. That's a good test, okay? Recently, we've come out with something called the 5th generation troponin. One thing great about laboratory medicine, whatever test we have, there's another one coming that's better, right? The 2nd generation, the 3rd, the 4th, the 5th, and each one is better, but microscopically better, okay? So by the time you get to the 5th generation, you know, the improvement's not too big, all right? But this is the test that's used in Europe. It was just made available in the United States in July, June or July, it was just approved. It's ultra-sensitive, okay? Ultra-sensitive. And the goal of this test is if it's positive, you know the patient's had an MI, and if it's negative, you can send the patient home because you don't have to wait for a second test, all right? So that's the goal of 5th generation troponin. Now, the disappointment, okay? Right? Nothing's as good as it sounds. Tests in the United States are regulated by the Food and Drug Administration, right? And it's unclear if the FDA is going to allow the test to be marketed in this manner, okay? Because this would be a dramatic change in clinical practice, right? And so as of now, this test is not widely used as people are trying to figure out how best to use it and if, in fact, it will allow this to happen. Okay? If that test actually works as well as it says it works, that would really change the way ER triage is done. Do you see why? Right? I wouldn't be sitting in a room playing with my phone, right? I'd be going home complaining, why did I have to go to the ER, right? Because there was nothing wrong with me. So problem is, the test hasn't been released. A recent article from Australia, where the test is being used, was a little disappointing in that didn't change clinical practice, right? Because doctors are doctors, and they, you know, yeah, sure, it's negative, but I'm going to wait. So in Australia, anyway, in this big study, it didn't change clinical practice much. My guess is if the test really turns out to do what it's supposed to do, it'll take a couple of years. I don't know what you think, but usually things like this take a couple of years before people finally come around to accepting the fact that you don't have the patient hanging around. But this is not in use yet, but it's coming. Okay. So CKMB, that's an older test. 20 years ago, it was the gold standard. And the problem with CKMB, and the real reason it didn't work out to be as great a test, I'm going to go through this pretty quickly. The real reason was it can be elevated for other reasons, okay? And low levels are present all the time. So it was one of these tests that if it went up really high, you knew the person had an MI, but it was possible for people to have non-myocardial damage and still have an elevation. Okay? You see what the negative... This was the first real test that came out. I was a pathology resident when this came out. So, and it's distributed. The only point of this slide is to show CKMB is the one that we're looking at. That's what we measure. But you notice it's both in skeletal muscle and heart. So it's not just in the heart. And because of that, there was confusion with results. Okay? And there's different ways. You know, people would say, what's the percentage? They created this thing called an index. How much CKMB is there compared to the total CK? And I'm a believer whenever there's an index, there's usually a problem, right? Indexes are sort of, I'll compare this result to that result, and depending on the ratio, it means this or that. And, you know, not as valid. This is an older test. I'm only mentioning it for a reason. You'll see why. There's a better test, CK isoforms, but the reason we don't use it, no rapid method, so we're not going to use it. Myoglobin. Myoglobin's an interesting test. Myoglobin's a test if you have any muscle injury, you're going to get a high your myoglobin goes up, right? Did you hear about the March myoglobinuria, right? When the soldiers go on a 50-mile march, and then they come back and they have red urine, right? Read about that? No? What's the world coming to? They don't know about March myoglobinuria. Oh, there's probably more things to learn about, but when I was in medical school, that's all we had to learn, so it was something you learned about. Go out for a 50-mile bike ride, you'll have myoglobin in your urine. Take it from me. Okay, we might not be able to measure it, but it's there. So it's sensitive, any muscle damage, but it's not specific. Any kind of muscle damage is going to make myoglobin positive. Any kind. All right? But the beauty of myoglobin is if myoglobin's negative, you haven't had any muscle damage. If it's positive, it means nothing. It doesn't mean you had an MI if it's positive. But if it's negative, it means you had no muscle damage. And the heart's a big muscle, right? So a negative myoglobin is thought to rule out myocardial infarction. Okay? People like to do it over a couple of hours. Some people do. Some people just do it once. Does everyone see why myoglobin might be a good test for picking out people who don't have cardiac injury? Right? It's a good test for that. It's of no value picking out people who have cardiac injury because it picks out any kind of muscle damage. So now we're looking at 3 different kind of tests we've seen. We've seen troponin that's very, very sensitive for myocardial infarction and is very, very specific test. We've got CKMB, which is a good test, but sometimes can give you a false positive test, but all in around, pretty good test. And you have myoglobin, which the exact opposite is an extremely good test when it's negative, but being positive doesn't mean anything. Flip it around and think about troponin. When it's positive, it means a lot, okay? But when it's negative initially, it doesn't mean much because you gotta wait. You see that? The contrast to the opposite ends of tests. Now, the better test is troponin, because what are we trying to do? We're trying to diagnose it. But the reason sometimes people like to use myoglobin, it's a quick and dirty way to say, no, the patient didn't have anything. They don't have to stick around here for 6 hours. It's negative. The troponin's negative. We can send them home. Right? Any questions on that concept? Okay. Now, this is when we turn off the PATHO. This is what's important to know, this little chart. It looks busy, but it's pretty simple. And I'm going to focus on 3 things on the chart. Hopefully, it moves. So here's a patient has an MI, and I get CKMB rising. See, it rises rapidly, almost to the peak at a day, and then trails off, and maybe by about 3 days it's negative. You see that? They can't see this on PATHO. That's the good news, right? So up it goes real fast, right? And then it comes down. Troponin starts here and is positive a little sooner. You notice that? I'd have to blow that. I don't know where I stole this from, but you can see on this graph that troponin crosses the normal range sooner. So troponin is positive sooner. And notice what it does. It continues to rise, stays elevated for a long time, and then starts to fall down. So, which has a wider diagnostic window? Troponin or CKMB? Troponin. That's an important fact to keep in mind, which we will come to. All right? So now you can see when someone shows up why troponin is a good test. It becomes positive pretty quickly, rises continuously, and this is why you can do the serial testing, right? Because you test it now, you test it a couple hours later, it's risen pretty sharply, right? Make sense? So that's the idea behind serial testing, because maybe the first time you test the patients here and it's negative, the next time you test them, they're positive. And then you got your diagnosis, okay? Assuming there's no false positive results. It's as simple as can be. That's how cardiac testing is done. Didn't have to bother coming here. All right. So you're all thinking that for sure. So let's think about the changes in acute MI. So first few hours, 1 to 6, myoglobin's positive, and I mentioned CK isoforms, but we don't use them. So myoglobin's the earliest, would be positive. Middle area, I'm saying 6 to 12 hours, all right? It might be 4 to 8 hours, but the point is it's about that time period, which is why, you notice we had serial testing 6 hours apart, 4 to 6 hours apart. That's because you want to catch one positive versus the next, right? Does that make sense? So if the person just collapsed on the street from their MI, it's probably not going to turn positive for a bunch of hours. On the other hand, if it happened a couple of hours beforehand, when they come in, it might in fact be positive. So that's the whole fallacy with starting the clock when the patient comes to the emergency room, right? That's just making the assumption it happened as they walk in the door, and you got to wait that time for it to become positive. All right? And then you can notice, forget about this part, but troponins stay positive for a really long time. That would be the absolute longest, but we'll say 7 days, right? 6 to 7 days. And the reason that's important is if you looked at my chart, this is where troponin has really got its real great value, is the patient can come in a day or two after they've had their infarct and still be diagnosed. Most of the other tests wouldn't work. And, you know, as I said, patients don't necessarily come in. You know, they were at a party at their house, it was Saturday, I don't know, they didn't feel too good, they thought it was indigestion, right? And then they waste their day watching football games. And then they wake up on a Monday and they're not feeling well, and then they decide to go to the emergency room because they don't feel good. And when they go there, now it's already been 24 hours maybe, or 36 hours since the insult that occurred. Well, the good news is with troponin, it's still going to be positive, right? It'll be a positive result because it stays positive for a longer period of time. All right? So you could see immediately after an MI, forget about this last test, myoglobin could be positive, but the others are generally negative. 7 hours, right? Slightly elevated, okay. 12 hours, you can see troponin is positive, so is CKMB, okay. 14 hours, CKMB, troponin, I'm tracking it out, okay. Creatine kinase CK generally doesn't work as well either in older patients. That's why we stopped using it. Older patients, females, older patients have less muscle mass, okay? Other than me, but most older patients have less muscle mass, right? Females generally have smaller muscle mass. So there's less muscle to release, right? Patients that have had previous MIs oftentimes don't release much creatine kinase, CKMB, and subendocardial infarcts. So that was really what did in the CKMB test. There are a lot of limitations to it. And, you know, patients older than 70 are more likely to have an MI than people in their 30s or 40s, right? So that's why this test is not used any longer. And it's been replaced by troponin, okay? Here's something interesting, though. A week after having an MI, troponin still might be positive, right? While the other tests are negative. Now, why might this be important? Any ideas why might this fact that CKMB has become negative and yes? Excuse me?
Recurrent MI.
All right. So if the person at day 5 or 6 had another MI, okay, the troponin is still positive. But all of a sudden, you'd have the opportunity, right, for CKMB to go up again. Remember, it goes back to negative after a couple of days? So let's pretend I have another infarct here at day 4, day 5, right? If I go test the troponin, it's going to be positive. But if I could do a CKMB, it should be negative, but if it became positive, then I'd know I had a reinfarction. How's that sound? Now, you know, does it have to be done that way? No, you could watch the troponin go up again. But I'm just showing you, the purpose of this illustration is to show how different diagnostic windows could be used, right? So that's a good example of taking advantage of a shorter diagnostic window and applying it to a situation where the test with the longer diagnostic window already has a positive result. Make sense? Now, I know it's hard to believe since most lectures don't talk about anything that has any matter to common sense or what you do every day. But this actually is important, this lecture. Not because I am giving it, but because these are commonly diagnosed diseases, right? And you need just to understand the time nature of a test like troponin, right? You got to wait for it to rise, and that over time it will fall. And another test, which isn't used very much, CKMB, rises more rapidly and falls off. And in a rare time when someone might have a reinfarction, you can take advantage of that. Different diagnostic window. And finally, a test like myoglobin, which doesn't get a lot of traction, is a very, very good test for ruling out, because if it's negative, you haven't had any muscle damage, but it's really useless as a positive result. Does that make sense? If it doesn't, you can say no, and I'll explain why. You know, you don't have to agree with me unless you want to leave. That's probably the most important thing on your mind. But don't you worry. That's coming soon. Okay. Anyone have any questions so far? Have we lost? Oh, he's still there. He's still there. He doesn't know I'm talking about it, but he's back. Thank you. I was telling Dr. Shaw, that's why I used to sit in medical school. I sat right in that right-hand corner reading the newspaper, and our amphitheater was much steeper, so you could really, really be not seen unless you tripped and fell down the stairs. Yes?
Is there a change in the...
Yeah, it can be different, and that's why the fifth generation troponin that I mentioned before, because depending on the type of infarct you get, non-ST, you don't get as much release, and so they're much more difficult to diagnose. So that's why there's a lot of folks. Most of these, you know, you're a clinician, you can correct me. But I think most of the time, this isn't a very complicated diagnosis in the ER, but some of the time, right, with an example that you're giving, some of the time it's more difficult, and some of the time a more advanced test like I'm describing would really be helpful. All right? But this is a pretty standard diagnosis. But yes, that's why people are looking at the fifth, and that's what it's all about. It's continually, constantly trying to weed out and identify patients who wouldn't be otherwise identified. And that CKMB would be useless in that example, right? It doesn't rise enough. Okay, let's see if I can really zip ahead. Okay. This is all in your handout. You can read it, how to use the test. It's pretty straightforward. And you'll hear about this in your they're little, right, the groups? Little groups. 16, well, 16 they notice when you're not there. Right? When I was in medical school, we had small groups too, like 12 students, you know. And I remember I went away with some friends and we blew off 2 of the sessions. And I went to the 3rd session and I realized that, you shouldn't do that when it's a small group of 12 people. Started asking me all the questions, Mr. Decrease, what do you think of this? I wasn't here. Mr. Decrease, what do you think of this? Oh, I wasn't here. And then eventually, Mr. Decrease wasn't here. We won't call on him. Okay. But you'll all attend. All right, so we'll skip through. And again, I want to go to, so here's the what do you call it, the final summary of my lecture. So usually do the test on admission, person shows up, and we're just assuming admission is when it happened. Probably completely wrong, right? And then we do it in intervals, and obviously you can stop doing the test when it's positive. Some people say keep doing it. Why? Because there can be some predictive value for the patient's long term what the total value is. Do they do that here? Yeah. Because the peak value can help you give risk assessment to a patient. Now, I don't know how happy the patient is when you give them the risk assessment. I have good news for you. Your troponin went sky high, and your risk of a reinfarct is 82%. Well, thank you very much. Thanks for that valuable information. I will update my will. Just kidding. But you see the reason it might be of value, because it actually is, and there are a lot of predictive models out there. We were discussing the models that tell people what their approximate risk is, right? When you tell someone they got a 10% risk of dying of myocardial infarction, you get their attention, right? Even though it might be relatively small compared to something else. All right? So this is what you need to remember. And you need to remember why we have to do it serially, because the tests rise over time. And troponin is the gold standard. You know what a gold standard is now? And troponin is the gold standard. And we see how it rises, and it stays elevated for a considerable period of time. No test is perfect, right? And that's why you always have to, and this is what happens these are the small percentage cases where, the test troponin is vaguely positive, but I'm sure that patient had an MI. Or, the troponin is positive, but I don't think the patient had the MI. That's usually not the case any longer because the tests are pretty precise. Okay, I think that'll be it. Thank you. Off to lunch. And not bad applause from this number of people. Thank you for attending. It made flying back from Tucson worth it.